Professor Petrov, Professor Stankev, thank you for the kind invitation. I would like to share our experience with physician-modified endografts. And the topic is, where are the limits and the lessons learned from our first cases. We know that the standard endovascular treatment with TEVAR and TEVAR is depending on the good quality proximal and distal landing zones. And this treatment is very well established when we have aneurysms with no main branches coming from the aneurysms. But what can we do when the major vessels are involved or had to be covered, like in these cases with aneurysms of the aortic arch or very short neck or pararenal or uterine aneurysms. Of course, we have options for open repair or hybrid where we can debranch the main vessels and after that put tube graft over the ligated main branches. This can be done also in the territory of the arch, like in this recent case, where we have a huge aneurysm of the arch and also thoracoabdominal. We performed the branching with the help of cardiac surgery department, and after that, placement of thoracic stent graft. But in many cases, the patients are not suitable for open or hybrid repairs, and then the options are entirely endovascular with fenestrated or branch devices or with parallel grafts. Since we started our program with fenestrated grafts 2 years ago, our preferred approach is with fenestrated grafts. There are currently two main modalities. These fenestrated or branch devices can be manufactured by the companies specific to the patient's anatomy, the so-called CMD, company manufactured devices or custom-made devices, or they can be produced by the physician immediately before the implantation from standard thoracic or bifurcated endografts on a back table for the implantation. So we know that CMD devices have some time for manufacturing and they are pretty expensive. On the other hand, the physician-modified grafts are more easily accessible, they are cheaper, there are some legal issues, but and there are no standardization. It's a pity for us, but practically CMD devices are not accessible in Bulgaria up to now, and this makes the PMGs really a viable option, and this is our preferred or in fact only possible way to do it. This is our first case done 2.5 years ago of 68 mm symptomatic pararenal aneurysm. We used Endurant 2 graft with 2 fenestrations reinforced with the tip of 014 wire and also used reduction ties on the back of the graft in order to be possible some rotation and adjustment of the graft during the implantation. This is the final result. Our personal fears in the beginning were will we be able to measure the fenestrations the right way, will we make the fenestrations correctly to be durable? Will it be possible to reassemble the graft in the delivery system? Will it be possible to achieve the right position of the graft and the fenestration? Will it be possible to cannulate the vessels and so on? And also there are some not so important, but also some issues about the anesthesia, access, coagulation status, which makes really in the beginning very, very stressful situations. We started with easy cases in the beginning, but 1 year later we had to deal with this one, giant symptomatic juxtarenal aneurysm with huge angulation of this patient, which is 88 years old. You can see what is the situation. We decided to try, because the patient refused any other options, to perform fenestrated physician-modified graft with 4 fenestrations. It was relatively easy to position stents in the right renal and the mesenteric artery, but in fact the left one was a little bit lower than expected. We struggled a lot to cannulate this artery with 2 wires in the beginning. After that, to put we succeed to put a renal stent, and after that a coronary covered stent. And this is the final result. This patient is doing very well, and this is the CT angio 6 months after the implantation. When to use fenestrations and when branches? This is a question which is well established. When the distance from the fenestration and the ostium of the targeted artery is more than 5 millimeters, it is thought that it's better to use branches, because this gives better stability of the reconstruction. And this is the first case in which we used 1 branch and 3 fenestrations, symptomatic juxtarenal aneurysm. This is the device. We had to use to stent before the intervention the renal arteries, which were very, very stenotic, and use also endurant ortho-uni iliac graft and iliac extension with fenestration to perform CRAP, because also there was very very severe stenosis and the calcification of the iliac bifurcation, aortic bifurcation in iliac arteries. So this is how it looks like. We have reduction wire on the back, and also a wire for precannulation of this small directional branch for the left renal artery. You can see in this case it's easy to position the graft because we have stents in the renal arteries, smooth procedure, stenting of all 4 vessels with covered stents, and this is the final result. We used also physician-modified grafts in this thoracoabdominal aneurysm with quite dilated aortic arch. This lady has a previous aortic valvular replacement and prosthesis of the ascending aorta. We decided that it's better to go in the zone 0 and to seal with the previous surgical prosthesis of the ascending aorta. And in this case, we used 3 fenestrations with Ancura thoracic stent graft, reinforced and precannulated left subclavian fenestration, and 2 bigger fenestrations for the left carotid and brachiocephalic trunk. The this gives us relatively easy implantation because we have true and true wire for the subclavian fenestration. It goes exactly at the ostium of the subclavian artery, and this is the final result. This lady has to be treated on the second step for the distal disease with probably 4 fenestrations for the thoracoabdominal. So, where are the limits? Based on our very positive first cases, we assume that there must be almost no limits and every case could be treated with PMEG fever, but this is totally wrong. Our experience from the beginning is with up to now 14 fenestrations, fenestrated branched EVARs for complex AAA and thoracoabdominal. Most of them are PMEG, only one CMD device, and also 2 arch fenestrated procedures and several PMEGs for preservation of the iliac, internal iliac artery. We had good technical success in all cases in terms of no window leaks in the end of the procedure and patent target arteries, except in 2 cases. Both of them we had difficulty to position the in first case valiant captiva with 5 fenestrations. It was because there was extreme tortuosity, and finally we could not position the correctly the graft, and we decided to put it up above the celiac trunk. And the other one I will show you in this short video. This is previously stented thoracic aorta with huge aneurysm above the celiac trunk. You can see it. We decided to use again Ancura thoracic stent graft, conical one with 4 fenestration, and after that to put another proximal extension to seal with the old grafts. This is how it looks before resheathing the stent graft. You can see there are 4 fenestrations, reducing ties on the back. In fact, you can see now the graft is in good position, but after partial deployment, we found that there is some rotation, and in fact the position is not so good. We had to do some clockwise rotation, but it was absolutely not possible. We tried with some pushing and pulling to rotate the graft. Also we didn't succeed, and in one moment we are in a situation where the lowest fenestration for the left renal artery is just in front of the superior mesenteric artery, and we had also a wire in the celiac trunk. So we decided to use this fenestration for SMA and put a chimney for a celiac trunk. So this was not so difficult, but we also had to put another chimney after that for the left renal, which was partially covered. And you see the right kidney. The left renal artery is just below the open stent. And finally, we put another aortic cuff just to cover the proximally unused 3 fenestrations. So we succeed to spare the circulation of these critical visceral vessels, but in fact resulted with some endoleaks, probably from the gutters. And this patient is under surveillance now. We will check and decide later what to do. What we learned from this case is that familiarity with the features of the graft is extremely important. This was the first thoracic ancorae we used, and it has a connecting bar which makes it practically self-oriented in kinked parts of the aorta. And also using so long graft with fenestration in the distal part limits the control of the delivery system when most of the graft is open. Although we found solution to preserve the renal visceral circulation, we finished with endoleaked and finally unresolved problem requiring future and even more complex interventions. So where are the limits? In fact, we have some basic limitations. Up to now, we are struggling with mobile C-arm, in which we don't have a fusion system, and we have to choose between two EVAR and two TVAR grafts, which are available in our country. There are also anatomical limitations. It's best to have straight aorta without thrombus and calcification for good landing, and also perpendicular takeoff, if possible, of the vessels without stenosis and early bifurcations. And also, it's good to have good big access vessels, but this is not the situation many times. So the biggest problem is malposition of the graft and fenestrations. It could be a result of wrong preoperative measurements, or it could be because of change of the anatomy with the stiff wires inside. And in fact, both of these problems are mainly related to significant tortuosity and angulations in anatomy of the patient. So maybe in these situations, it's good to use 3D models or something else, maybe open repair. In conclusion, every case is a step up in the learning curve, and the difficult and unsuccessful cases are most educational. Good knowledge of the graft features and its delivery system is of great importance for creating the right modification and predict the behavior of the graft in the specific aortic anatomy. PMEG is our preferred and often the only option in many cases of arch pathology, TA, thoracoabdominal and complex AAA, not only in urgent and emergency situations, but also in cases like in ours when CMD are not available. Thank you.
Thank you. Thank you very much, Professor Nikolov. Extremely hot topic, very up to date, very good results. In fact, you mentioned that the results are extremely dependent on anatomy. In case the anatomy is complex, every single case can become complex, even the best planned. For one of the cases, I think the second one, in which you had a difficult renal artery cannulation,
yes,
probably it would be easier. It's easy to instruct somebody else after the procedure is done, but it could be have a little easier from above. I saw that you tried with several kind of curved catheters from below, because there is a tension between the axe of the catheter and the axe of the artery. And from above, it's much more easier to have smooth transition from the axe of the aorta and the axe of the renal artery. But nevertheless, great job. And you mentioned and you showed very well that sometimes the chimneys can be bailed out for fenestration, and vice versa. In some cases, fenestration can be bailed out for chimneys. So in case there is no success with one method, always we have to have plan B, because otherwise it can become really a disaster. Some comments? Yeah, yes. Professor Criado, one of the pioneers. Thank you. Thank you for coming and join us.
Well, congratulations on those cases.
Thank you.
That are quite difficult to do, obviously. But I think there is a very important future for this so-called physician-modified stent grafts. I was a little confused as to, on one of your slides, you had like 4 different expressions to say the same thing, and I'm not sure what you meant by that. Different names, like physician-modified stent graft, endograft.
I just tried to mention how
But
different.
it's all the same thing,
It's all
right?
the same and different names.
Yeah,
Physician-modified stent
yeah.
grafts,
As I said,
physician-modified device.
I think it's a very important development that is happening all over the world, including the United States. And the main reason why they have a big future is that they commercially manufacture devices, and in the US we only have one that is FDA approved, and it's the Gore Timber device, are difficult to, they're not readily available, and they are extremely expensive. Just to give the audience a sense of what a timber case costs in devices alone in the United States, more than $70,000 in devices alone, just the stent graft devices, not counting catheters and many other things that we use in those surgeries. So that alone explains why there is a big need for all of this. But I believe the future is probably going to be by way of a more standardized way of making the fenestrations and modifying the stent grafts, because it is extremely difficult to get it right, and your last case, you know, is an example of that. And of course, you're right, anatomy is ever variant and very challenging and difficult, but there are ways using AI in particular that I think is going to make it standardized. And Terumo is a major company, of course, that is developing such a system that is probably going to be more widely, it's already available, but in a very limited fashion, and it's going to be more widely available in the years to come, and perhaps the other major companies will do the same. So again, congratulations.
Thank you.
Thank you, Frank, and thank you, Professor Nikolov. Please join us.